Well, hello everyone. This is Professor White, and this lecture today we're going to be talking about the medications that are used to treat tuberculosis. So, tuberculosis is actually caused by some acid-fast bacilli, which are called mycobacterium. So we often just say tuberculosis, but understand it's often written as MTB as well. But in general, it's tuberculosis. When we think about tuberculosis infections, the most common thought that should come across to your mind are the pulmonary tuberculosis, because most cases of tuberculosis do affect the lungs. In severe cases and in patients who are immunocompromised, and usually because of the result of HIV or other infections, and also in very young children, they tend to have more extrapulmonary tuberculosis. So this would be the tuberculosis going into extra areas of the body that are outside of the lungs, which is the definition of extrapulmonary. And then one of the most severe forms is miliary tuberculosis, and that's basically systemic and in the bloodstream, very rare, but we want to keep it that way. There are 3 phases of tuberculosis. The first one is primary infection, and basically the patient can be rather asymptomatic. Most cases the patient will have a good immune response and will go into the latent phase of tuberculosis. Now, during the latent phase of tuberculosis, the patient actually isn't contagious and it cannot be spread to others. So basically it occurs when those TB germs are present in the body, but they're not active or causing harm. However, if the latent tuberculosis bacteria become active and multiply, then the person can develop tuberculosis and become contagious. And that's why we have to do the treatment. So the difference between latent tuberculosis and active tuberculosis is latent tuberculosis, the patients don't have symptoms, they're not contagious. Antibiotic treatment usually takes 3 to 4 months, but it can progress to active TB. Active TB can be spread to others and has to be treated for much longer, and if it's untreated, can become deadly. So here's just a little bit more information about mycobacterium. So the mode of transmission is droplet, but those droplets can be super duper small and they can be expelled into the air by inhalation. So this is why we use N95s around tuberculosis, because of the size. And even though it's droplet, it's truly more of an airborne spread once those droplets are expelled with the coughing. And then the lymphatic system takes those bacteria and spread it around the rest of the body. Once the body walls off the infection, the bacteria can become dormant. Tuberculosis is by far and away a very slow-growing organism, and because of the type of bacteria it is and its own sort of protections it has, it's harder to treat, which is why we have multiple drugs being used to treat it because of resistance and for a very long time. So we've already talked about the 3 different phases, of course, being the primary infection, and then reinfection, which be a chronic form, and then dormancy, or that latent period. During that latent period, which would be inactive tuberculosis, the body would have a smaller amount of the germs that are alive but inactive, no symptoms, the patient doesn't feel sick, cannot spread it to others, and usually would have a positive tuberculosis skin test. But if you did a chest x-ray, it would be negative, and their sputum would be negative. So let's take a little bit look about the history of tuberculosis. It's pretty interesting. Did you know that March 24th has been designated as World TB Day? It's a day to educate the public about the impact of tuberculosis around the world. And we can look at the history of tuberculosis to see basically how far it goes back. Tuberculosis was named tuberculosis in 1834, but it's been estimated that the infection may have been around for, tens of thousands, if not millions of years. The earliest written records of TB are from India about 3,000 years ago, China over 2,000 years ago. And in ancient Greece, Hippocrates identified tuberculosis as the most widespread disease of the time and noted that it was almost always fatal. From the 1600s on to the 1800s, 25% of all deaths in Europe and the United States were caused by tuberculosis. But again, it wasn't until 1882 that Robert Koch identified the tubercle bacillus as the agent. So wasn't that long ago. In the 1800s, there were a lot of public health campaigns about overcrowding, public spitting, things of that nature. And it was in the 1950s that the CDC actually published the nationwide TB data from the United States for the first time. And so we went on basically a war against that. And I'll show you this picture as we go in here so you can kind of see it. But because of everything that was being done with tuberculosis, we had sanatoriums, things of that nature. It was a huge public health concern that our incidence of tuberculosis actually decreased until about 1985. And at that point, it began to rise, but that was also the AIDS epidemic at that time. So that's why we had a lot of people who were really immunocompromised. And that finally peaked in around 1992. And that's because we started to have better treatment for AIDS and HIV, and people weren't getting as sick as a result. And now the concern is multi-drug resistant tuberculosis. And the reason for this multi-drug resistant tuberculosis is because of non-adherence to the treatment. All right, so let's go and look down now a couple of slides, and we're going to talk about multi-drug resistant tuberculosis. So multi-drug resistant tuberculosis is tuberculosis that's resistant to the most common drugs used to treat it. And those would be our first line drugs, isoniazid and rifampin. And then we have an even worse one, which is the extensively drug-resistant tuberculosis, which is resistant to almost all the drugs, as well as the best second line. So this is not the way we want to go. Patients who have AIDS or otherwise immunocompromised, as you can see here, are at the biggest risk for having extensively drug-resistant tuberculosis. And this is why, my friends, we use multiple medications and use such a long length of therapy to treat tuberculosis infections, so that we are not leaving weakened bacteria that have been exposed to the antibiotics to be able to get resistant to them. All right, so let's talk about diagnosis, right? So how is tuberculosis diagnosed? The first thing is the tuberculin skin test, or the PPD, also called the Mantoux test. And this is the one that we're familiar with, where we get a little bit of the purified protein derivative injected intradermally, and then it's looked at. And we'll talk about that a little bit further down. And if that is positive, then the next thing to look at is a chest x-ray. And a chest x-ray is just going to tell us if there's active disease. And if there are any signs of tuberculosis, then the culture is done, and that is the acid-fast bacillus. In order to do that test, it's 3 consecutive sputum samples first day in the morning, and to see if they have it. All right, and then also that is cultured, or they do stomach secretions. The most common you're going to see, of course, is the acid-fast bacilli sputum. All right, so here are the antitubercular drugs, and I've highlighted the most common of the first-line drugs. There's basically 3 different groups. You have the protein wall synthesis inhibitors, and that would include those old ones like streptomycin, kanamycin, also rifampin. Isoniazid inhibits cell wall synthesis. And then some other mechanisms of action down there. But again, this is just a list. Let's take a look at this one here, which I think is pretty nice. This is the Ripes mnemonic. So first-line treatment would be rifampin, isoniazid, pyrazinamide, ethambutol, and streptomycin. All right, so on the next slide, we are going to talk about the PPD test. But again, this is a nice little slide because it tells you the most major side effect of that class of medications. So the PPD, 0.1 mLs or 5 tuberculin units are administered intradermally. And if the body reacts, that means that it has a reason to react, that it's been exposed to tuberculosis. When these are being read, it is by induration and not just at the redness, so you actually have to feel at the site of the injection. And I'm sure in your surgical classes or your medical classes, you'll go into further what is a positive PPD, what is negative, and what the various sort of deals are as far as if a person is immunocompromised or not. A brief nod to the BCG vaccine. 80% of the world's children are actually vaccinated with this. So again, it's not something that we do here in the United States, but we do have many folks who are from other countries who may have been exposed to this. And the reason that this is done in many other countries is because of how severe the tuberculosis infections are. And this prevents generally the most horrifying of the diseases, including the extrapulmonary and miliary versions of TB. But again, it doesn't actually prevent any infection. But what it can do for us and what's important is that it can cause a false positive result on the tuberculin skin test. All right, so let's go talk about the drugs now. The reason we treat tuberculosis the way we do is to prevent infectious passing of the disease. So, major effects in the considerations for therapy is we want the reduction of the cough. And if a person is not coughing, then it reduces the infectiousness of the person. And that usually takes about 2 weeks if the strain is drug sensitive. Most strains and cases can be cured, but it takes a long time. It can take up to 12 months or even longer, depending on the strain. All right, so our treatment guidelines recommend the use of multiple medications because of the increasing presence of resistance. So what they like to have done is that there's drug susceptibility testing on the first species that's isolated from the patient, and that's to make sure that we're treating them with medications that are effective for that strain. But even before we get started on that, the patient will begin a regimen that has multiple drugs. And that's why I put this picture of multiple pills there. And that is to reduce resistance. After susceptibility testing is completed, there may be an adjustment of the drug therapy that's needed. The patients must be monitored to make sure they are adherent to the treatment. And this is a close monitoring. The Department of Health is involved in this. And in cases where a person is not adherent to the therapy, there are mechanisms in place in all states, basically, that state that the patient can be medicated over objection and can actually be removed and placed into a facility or be forced to come in to the health department for their medications. Again, and it's all in with the end goal of decreased resistance and decreased contagion. You can pause on here and take a look at what I've written here, but it's basically giving you some things to make sure that the patient is adherent with therapy, that the right therapy is ordered for the right duration and the right amounts and the right combination, so that we can make sure that this disease is not spread. The first slide we're going to start with is not one of the more common ones, but I think you should know about how hard it is to develop drugs to treat these infections. So this medication that is listed here, betaquiline, was the first drug that was approved in over 40 years, and that was in 2012. So this is, at least 12 years later. This is used to treat tuberculosis if there are no other options, so that's multi-drug resistant. And because of the side effects of it, including headaches and chest pain and that QT prolongation, which can cause serious cardiac adverse effects, should be taken with food. And protominid is another new drug that's used for multi-resistant TB, and it's also often given with this one that's above and linezolid. So again, just a nod to the fact that we don't have great new options for the treatment of tuberculosis. It's an old disease with old treatments. All right, so ethambutol is a bacteriostatic medication that impacts the cell wall, but the exact mechanism is really unknown, but it does suppress RNA synthesis. It is contraindicated in those who already have optic neuritis if they're under 13 years old. And understand that a baseline and periodic eye exam should be performed because of the potential for retrobulbar neuritis. It causes the potential decrease in visual acuity and even blindness. The major side effects, again, most severe would be optic neuritis and blindness. Sometimes a patient can develop hyperuricemia, which is generally asymptomatic, some GI distress, sometimes, very rarely, thrombocytopenia, renal damage. But again, this guy's claim to fame and why I have a person using a blind stick is the optic damage, including blindness. Isoniazid is bactericidal overall to those that are in division stage, but it's bacteriostatic if they're resting. The exact mechanism of action is pretty well unknown, but it does inhibit the development of their cell wall. There are strains that are emerging that are resistant to this, and it is part of the cocktail that is given. Sometimes it's used alone, but most of the time in combination with other medications. It is definitely contraindicated in liver disease, so you would want to make sure your patient has liver function test at the start of treatment and regularly after. If a person drinks alcohol, that's going to increase the risk of hepatotoxicity. So they should limit or avoid alcohol use. In fact, in general, for our medications here, I would say avoid would be the teaching. Peripheral neuropathy is a potential adverse effect, and one of the ways that we treat that and prevent the problems related to that is to give pyridoxine, which is a B6 vitamin. So that may actually reduce the amount of peripheral neuropathy that they have. Some other things, taking isoniazid with phenytoin can lead to increased toxicity of the phenytoin. PZA, or pyrazinamide, is bacteriostatic, and not really sure exactly how it works, but it is contraindicated in those patients who have pre-existing liver disease and those with gout. It is used in conjunction with other medications to treat active tuberculosis, and it may also be used to treat latent tuberculosis as well. Some of the more common side effects or adverse effects of this would be the polyarthralgias and liver toxicity and hyperuricemia. So it can cause gout-like disease. Rifampin is bactericidal and it inhibits protein synthesis. It is the primary medication used for the treatment of tuberculosis, but drug resistance can develop quickly to the med, so it's always given with at least one other medication to treat tuberculosis. Liver function tests should be done at baseline and regularly thereafter, and our patients need to be instructed that body fluids, including urine, sweat, tears, and saliva, may turn reddish brown. That is a harmless effect. Okay, so let's go ahead and educate our clients on what they are going to see so that it doesn't alarm them. It's nothing that needs to be reported. It is expected. Women taking oral contraceptives and rifampin need to be counseled about other forms of birth control because of the impaired effectiveness of their oral contraception. And that's why I put a lot of red on this slide though for you guys about the change to the reddish body fluids. Streptomycin is injectable form only. It is an aminoglycoside. So remember, our aminoglycosides, we're going to look at them as causes for ototoxicity and also nephrotoxicity. So that's why I have a picture here of people working on an ear and working on a kidney. All right, so let's wrap this up. Nursing implications. So in general, our patients will need to have their liver function test before receiving INH or rifampin, and especially those who are older, especially if you have anybody who has a history of alcohol use. You have to make sure you're looking at the contraindications and potential interactions. And at this point, patient education is absolutely critical. This therapy for tuberculosis may last for up to 12 months and sometimes even longer. The patient has to be pretty well regimented and take the medications exactly as ordered at the same time to make sure that they don't end up with a drug-resistant strain of the disease. Because of the potential for liver toxicity, patients should not be drinking alcohol. They should not take any over-the-counter drugs without checking with their provider first. Many of the oral preparations can be given with meals to reduce the GI upset, even though there are some recommendations to take them surrounding the meals. And the patient does need to report any adverse effects. So here are the things that they should be reporting. Burning or tingling in the fingers and toes may indicate that there's peripheral neuropathy, so the provider needs to be notified immediately. Any jaundice or signs of liver dysfunction. And you want to monitor for the therapeutic effects. Remember what we're after here, and I'm going to wrap it right back up to the beginning. We want the patient to not cough as much so that they don't spread the infection. And then we can make that infection go from an active form to inactive or latent form in which the patient would not be contagious. We want to have a change for the better in their lab study results, so culture and sensitivities, and that would mean like negative sputums, and also negative chest x-rays. And if your patient is not showing therapeutic response to the medication, then our fear is that they may be having drug resistance, and so you would want to provide that information to the provider. All right, guys, so this one wasn't terribly long, but hopefully you've enjoyed it greatly. So TB or not TB, that is the question. Remember to make sure we're practicing good infection control guidelines for any patient who is suspected of having tuberculosis. And with that, I bid you goodbye. Thanks so much.